Thank you and good evening. Thank you, Heath and Colin and VAC, for putting together this forum. I think it's really important to be able to bring together people from the community who are interested in HIV prevention and in PrEP in particular. My two other speakers will speak to the study tonight, so I'll talk a little bit about it, but it won't be all you hear, so there'll be time to navigate the study a bit further, but I've been tasked with giving you some sense of the science, and I'll also give you some of the study design of the study and some of the issues that you might also find might be a little contentious. So I really look forward to your comments. So in Australia we have, well, in the world there are a number of strategies that including having a projector that works, to reduce HIV transmission. Oh, thank you. Oh, okay. That's okay. So there are a number of strategies available to reduce HIV transmission, and all of them are available in Australia. Except for vaccines, because then we don't have one yet, no one yet does, and the microbicide that was used in South Africa. But we have all the others disclosures. We have self-disclosure, we have diagnosis to oneself, and so in a sense disclosure to oneself, disclosure to one's sexual partners. So I'm going to use the slide as my cue. Circumcision, which is used in countries with very high prevalence, but actually circumcised men have a much lower risk of acquiring HIV. About 50% of Australian men cross-sectionally are circumcised, but it's much less common these days in younger men. We have rapid testing. We have testing of STIs and HIV, and we have rapid testing, such as the Pronto Clinic auspiced by Burnett and VAC, which is great. We have post-exposure prophylaxis. We have PrEP, which we're talking about now. We have people making sense of the science and trying to use different sexual positions to minimise risk. That's the community taking on the science and saying, okay, I'm going to understand this and try and live it. We have treatment as prevention, so positive people are treated and embrace their treatment as best they can, take their medications, and that greatly reduces the chance, the science is really coming out on that, of transmitting HIV to their sexual and injecting partners. We have needle and syringe exchange programs. We have IVF throughout Australia for couples seeking to conceive, and we have male and female condoms, although, as you know, female condoms are tough to get. Despite that, and I'm really sorry you don't have my slides, but we still have a rising rate of HIV infection, so that in 2012 we had 1,253 people diagnosed with HIV, and that was the highest rate in 20 years. So despite all of these efforts, we can't get it right. People are people, they have different strategies, not all strategies are perfect, so we have to go forward with what we have. And tonight I'm going to focus on PrEP. So, pre-exposure prophylaxis, do you think the slides will come? Yeah. They're coming. All right, so I'm sorry, I'll just keep talking. So antiretroviral agents are used to prevent HIV infection, as you would know, and that's pre-exposure prophylaxis or PrEP. And in most of the studies to date, they've taken the form of oral medications, that is, tablets taken usually on a daily basis. And they are used, those tablets, to prevent HIV acquisition from sexual exposure, injecting exposure, and also in conception. There's trying to use PrEP in couples trying to conceive. Usually, as I said, they take the form of tablets. But interestingly, and I think it'd be great to be talking in the next 10 years and see where this space has gone, but there are now long-acting injectable drugs that have been used in primate models that may in fact have been shown to protect in monkey models just recently HIV infection. So it's a monthly injection or it's 2 monthly injection, and there's a lot of work being done on delivering prevention in that strategy, so it takes away the issues around adherence, so the difficulty of taking tablets every day. Most of the studies to date, individuals in the studies have been asked to take the tablets daily, and that's what this study in Victoria will be, a daily medication. And the side effects when you compare placebo versus the real drug in these studies, individuals who got the real drug, they didn't know they did, but they did, when they look back, they found that nausea and back pain was significantly more likely in the individuals receiving the real medication versus those who had the placebo. And post hoc, they've gone back and done analyses and found that in individuals receiving PrEP, Truvada, that is, that there was a small but statistically significant decline in the strength of the bones, bone mineral density strength, and also a small but nonetheless statistical decline in the capacity of the kidneys to filter what the blood, etc. And that was reversible. The bone reversibility is yet to be ascertained. And interestingly, I should say that in the study which showed that there were some problems with diminishing in the strength of the bones, 10% of the gay men coming into that study already had very diminished bone density. So that is very interesting. And we're not screening individuals in this study for bone density, but this is some of the science. Now, when you say how effective have these randomised trials been, there have been several. And you know, a randomised controlled trial is like, well, we used to say like the Rolls-Royce, but I would say more we think now like a Maserati. It's the Alfa Romeo, it's the Aston Martin of clinical trials is a randomised controlled trial. People don't know which drug they're getting. You've got a 50-50 chance of getting the real drug versus the other. And people are followed up very carefully. The PrEP studies that have been done to date, I think without exception, individuals in the studies were seen every single month in the clinic and asked how they were they taking their medications, had they changed their sexual behaviour, did they have side effects, and they had HIV tests and STI tests, really very rigorous, in-depth study of people, not something that we could ask individuals out in the real world to come and do. So in those very highly controlled studies, the efficacy, in other words, how efficacious these drugs were in reducing HIV transmission versus placebo, ranged from 44% in MSM, in a study called the VicPrEP Study, up to about 75% in other studies of heterosexuals. So it wasn't bulletproof. And because gay men carry the burden of HIV in Australia, I'll reflect on the studies in gay men. What they found when they went back in the so-called VicPrEP study, which was purely about gay men enrolled in the United States, Brazil, Thailand and South Africa, was that when they worked out the guys who were taking the tablets every single day, in fact the efficacy was nearly 100%. So they figured out that if you did take the tablets every day, then it really does work well. But across the board, when they looked at the average reduction, it was about 44%. Now, why weren't the results better? I mean, it's a rhetorical question. Why wouldn't they be better? Well, let's think about it. When they looked at the studies in gay men, heterosexuals who are serodiscordant couples, or heterosexuals who are just at risk of acquiring HIV, and also injecting drug users in Thailand. So they're the three populations that have been studied: gay men, heterosexuals and people who inject drugs, and sex workers cut across those three study groups. They found that, for example, and again I'll reflect on gay men, in the VicPrEP study of gay men, only when they did when they looked at the guys who they knew were taking the real drug, only 50% of them had detectable drug in their system at any one time. So what that meant was their adherence was low. Does that make sense? So then they began to understand why perhaps the efficacy wasn't working. And not wishing to tout the heterosexual banner, but in the two heterosexual studies it was closer to 80% of individuals, when they did a cross-section, those guys who were on the real drug had drug in their system. And there are a couple of interesting studies of women in Africa that were complete failures, and they only found 30% of the women on the study drug who really had drug in their blood. And they were sex workers, they were young, they were disenfranchised, and they think they were probably selling the drug or giving it to family members who had HIV. But so you say, why wasn't it efficacious? Well, presumably a big part of it was that they weren't taking the drug. And then you say, well, perhaps it was that people changed their behaviour, and knowing that, or thinking they were taking a drug, they wouldn't have known if it was the real drug or the sugar tablet. Perhaps they reduced their behaviour, perhaps they changed their behaviour and in fact used condoms less, or had more partners and used condom less, or did a whole lot of things. But in fact, human nature being so tough to predict, in all of the studies, either the behaviour did not change, in other words, condom use remained about the same, or improved. And in none of the studies did the sexual partner number go up. In fact, in some studies it decreased. So I think what you infer from that is if individuals are coming to see a doctor every month, God bless them, they came every month, they would have been getting a lot of sexual health messages, do you know what I mean? So they probably did begin to take on board issues around behaviour, and maybe they were getting other healthcare needs met which may have made them feel better, more comfortable, or their situation changed, whatever. So I put to you that you could have actually argued, if you thought about it, that human beings would have, in those studies, taken their tablets every single day in order to change their sexual behaviour and not use condoms as much and be less casual about sharing injectable drugs. I'd put it to you that that would be a reasonable hypothesis. But in fact, it was the reverse. People didn't take the drugs, but their behaviour either was maintained or not improved, but less risk-taking. So just as you need to test hypotheses like those randomised control trials did, we actually, in a sense, here with the Victorian PrEP study, are trying to test a hypothesis. If we bring this prevention strategy in, and we must, but when we bring this in, how will it really play out? How will guys in Australia, and there are heterosexual men and women too, hopefully will be in the study, how will it play out? Will they too only take their drugs half the time? Maybe it won't be acceptable. Maybe people will be freaked out at taking a tablet every day, or they'll experience stigma from their casual partner or their new partner finding a bottle of Truvada in their bathroom. Maybe you're HIV positive. Are you HIV positive? I didn't know you were positive. No, I'm not positive. I'm trying to stay negative. And then there's the inference that perhaps you're sleeping around, or you're promiscuous. So there's a whole lot of stuff we're trying to unpack and understand, and hence we're taking evidence that was obtained in a very singular randomised controlled trial and take it into the real world, and hence this term demonstration project. Let's demonstrate how it works. Sorry, I'm probably going on a little bit here, but so to give you an overview of the study, I want to also say that the study has been funded by the Department of Health, and Gilead Sciences have donated the drug. So that's how it got about. We work in partnership with Burnett, Victorian AIDS Council, Monash, University of New South Wales, and we're going to invite 100 people who want to take PrEP to come onto the study, and we're also very keen to have equally 100 people who are similar risk of acquiring HIV but don't want PrEP, because we need to know about people who don't want PrEP. Why don't you want it? What are your attitudes, and etc. So they're equally important, the two groups. To come into the study, one has to be, as you can imagine, over 18 and able to provide informed consent and be contactable during the study with either an email or a phone. Fluent in English, because we haven't been able to translate some of the questionnaires into other languages, and HIV negative, and have some good kidney function, because as I mentioned earlier, some changes in kidney function can occur. And the aim of the study is to look at how many people that you invite to take PrEP will take it. So you look at uptake, how popular will it be, how will it have an impact on the so-called risk behaviour? Will people actually in Victoria, Australia decide, actually I'm going to give away condoms, or I'm going to do a whole lot of different things, I might improve my risk-taking strategies? We need to understand that. How acceptable is it? Will people take the tablets every day, and etc. And also we're going to look at the individuals who don't take PrEP. What we're asking them to do, just to focus on it for a sec, is, let's say you come to your GP and they say, look, actually you've had an STI in the last few months, and I think you've mentioned that you don't always use condoms. There is this treatment available called PrEP, and if the individual says, I don't want to take a tablet every day, and Dean will tell you most gay men in Australia at this point don't, then what we'd say is, look, could you come into this study anyway? And we invite people to do a 20-minute online single survey about PrEP and about their sexual behaviour and what they think about taking medication. And then, if they're attending the 4 clinics that are offering the medication and the study, any individual who's a gay man that attends those clinics, when they come for their regular STI and HIV, you would know, you quite often fill out a brief survey about your sexual behaviour in the last 6 months, and then you have an STI test and an HIV test. Well, we'll be asking the people who don't want PrEP to give us permission to follow how often in the next 24 months you do come in and have an HIV test or an STI test, and what the results of those surveys are. So we'll be able to passively, if you like, track the guys who are out in the world and not in the study, living their lives, and then we'll have the people in the study and we'll be able to compare them. Does that make sense? So you can see why the PrEP non-acceptors or the decliners are very important, because in fact in the future we'll be able to link those groups together and look at, in fact, to see whether there was the future decreased incidence of HIV and other STIs in the two groups. So thank you so much for your patience without these, without the slides. But let's say you're one of the individuals who says, no, I do want PrEP. Let me just, sorry, I beg your pardon. Oh yeah. If you're the person who says, no, I do want PrEP, the way you'd be, so you're 18 or over, you're contactable, you sign a consent form, you're HIV negative obviously, and your risk factors would be one of the following. That you have unprotected receptive or insertive sex, either anal or vaginal, so that covers people who are gay or straight. Okay. And it's like, I think this is like, Spinal Tap. You know? And that thing is coming down. Sorry. So you're HIV negative and you're having receptive or insertive anal or vaginal sex with a HIV positive partner. And we'll talk about in a minute later, what if your partner's got an undetectable viral load? Is this study for you? Because that's really important. Here we are. Or you're having receptive unprotected anal intercourse with casual partners whose status you don't know. Or you're an uncircumcised male, because unfortunately that means you carry a greater risk for acquiring HIV, and you have insertive unprotected anal sex with casual partners. So they're the kind of sexual behaviour criteria that we have. So that would say, yes, you probably are at greater risk for HIV than other people who practice, say, safer sex. So what we'd say to you is, okay, thank you for coming on board. You're going to be enrolled through either Melbourne Sexual Health Centre, Northside, this is on another slide, Prahran Market Clinical Centre Clinic. They're the 4 clinics, not the Alfred Hospital. At baseline, you would come in, you'd have an HIV test and we'd have a hepatitis B test, because the drug Truvada, interestingly, also treats hepatitis B. And we think that's a separate issue and probably should be addressed separately and not in this study. So sorry, anyone who's a hepatitis B carrier can't come in to the study. And we'd look at your kidney function, we'd do an STI screen, and then we'd say, look, great, you're in the study, could you, in the next 5 days, there's an online survey, which is your baseline survey, could you go home or go to a cafe or wherever you want to and do this survey that Dean will talk about. And at 1 month, we'll give you the script, and at 1 month, when you come back and your HIV test is negative, then you'll get a call at home asking about you. The reason why we can't just say come back to your doctor all the time is because PrEP is not licensed in Australia, and a doctor can't attract a medical provider number to talk to you about your PrEP and how you're going. Does that make sense? But a doctor can see you every 3, 6 or 9 or 12 months, because we have Australian guidelines about regular STI testing for men who may be at sexual risk. So we had to straddle those sorts of contingencies. So the phone call at a month, are you okay? And if you're not, of course you come into the doctor. I mean, of course you would come to the doctor if you're not well. But subsequently at 3, 6, 9 and 12 months, if you're still on PrEP, you don't have to take PrEP for 12 months. That's part of the discovery. The discovery is how long will Victorian men take PrEP for? Will it be for 12 months? Maybe it'll only be 6 months, then the relationship changes and things move on. So you don't, of course, have to take the drug for 12 months. But if you did stay on it, we'd see you every 3 months, check that you're HIV negative, check that you haven't got an STI. We're going to do a particular blood test called a dried blood spot test, which actually allows us to measure the level of drug in your blood. We won't know that, the doctor will never know that, but at the end of the study we'll be able to look back and say, heck, you know, those 70% of people took a drugs every day of the week, or oh dear, only 30% of people took the drug every day of the week. Do you see? So that's where the research side comes in. And similarly, when you do these online surveys, that your doctor won't find out about what you say. You might go to the doctor and say, yeah, I take the tablets 7 days a week, and you only take it 4 days a week. But you, or hopefully on the survey, individuals will be more candid, so we'll have a better sense. Does that make sense? But the doctor will not know that, so there's all that privacy is maintained. And then when you finish your PrEP, whenever that is, we would also ask consent, or the individual to ask consent for us to continue to get for the next 12 months or so any STI results from that sentinel surveillance network. Does that make sense? So I better finish. Sorry, I do want to show you this though, because this I think could be a bone of contention, and it would be really good to have it discussed at this forum. At the Alfred Hospital, as part of the consent, our ethics committee and the legal team have said that as part of the consent, the individual says if you choose to accept PrEP as opposed to be a decliner of PrEP, as part of your participation in the study, you'll be expected to take, and I'm sorry, that sounds very paternalistic, but this is the legal approach. You'll be expected to take Truvada every day as per the instructions. You'll continue to use safe sex practice, including the use of condoms, and that's where I think people may struggle. And you'll have regular STI testing as recommended by the study doctor. So it'd be really good to talk further about that. I think I'm probably running out of time. Again, this was just the strategies that I talked about that are present, and we have a study running in New South Wales, Victoria, and Queensland. Victoria will be the first cab off the rank. But I really look forward to talking to you about it a bit further. Sorry about the slides.
Well, thanks everyone for coming. Thanks, Edwina, for a great talk. So, as he said, my slide is mainly focusing on PrEP in practice, so how PrEP might work in a sort of real-world situation. And I'm hoping this is going to work. There we go. So I just thought this is my potential conflicts of interest, just for clarity's sake. So I do work in a private clinic that will participate in VicPrEP, and I have in the past received financial support from Gilead, who are the makers of Truvada, to attend a HIV conference. Why should we talk about PrEP? HIV transmission rates in Victoria and in Australia as a whole continue to rise. Over the last 10 years, every year on year, and I'm sure a lot of you will be aware of this, but year on year rates have increased. Number two, condoms don't work for everyone, and I think the medical community is starting to realise that this is an issue that we need to address. We obviously have been talking about condoms, and we need to keep talking about condoms as a form of prevention of HIV transmission and transmission of other STIs, but the reality is that not in every situation are they workable for people. And I'll have a slide later on in the presentation to explore that a bit further. Third point is PrEP is effective if you use it properly, as in if you take it every day. Makes sense. And as Edwina talked about, the PrEP study showed that very clearly. So an effectiveness rate of 92 to 95% if taken every day. Unfortunately, the issue is that people don't take it every day, but that's something that obviously the VicPrEP study will be looking at as to the reasons why. And the fourth point is people are already using PrEP. People in Australia are already using PrEP. It's just that it's not hasn't been licensed for it, and there's no mechanism in place by which people are supported in their PrEP use and to make sure that they take it safely. So it's that old thing where people are already doing it, we just need to catch up a little bit and make sure we help them out. These are the objections raised against PrEP. They're not my objections, but these are the objections in the media. So first one, providing PrEP will lead to more condomless sex. I think Edwina's already addressed that. Again, the PrEP study quite clearly showed, and some of the other studies quite clearly showed that just because people take PrEP does not mean they have more condomless sex. Obviously, one of the reasons we think why not is because people are supported in during these studies, and they're counselled on the need for safer sex practices. Number 2, PrEP will cause a rise in other STIs. Obviously, it will only do that if people have more condomless sex. And unprotected anal sex is not the only way that other STIs are transmitted. I mean, obviously, syphilis and gonorrhea can quite easily be transmitted by oral sex, and it's obviously a separate issue altogether. Number 3, PrEP causes long-term side effects. It does. But people may not be on PrEP long-term, so these are things that we need to consider. PrEP is expensive. Is it too expensive? Other drugs are expensive also, and if it all depends on, if you can prevent HIV transmission with PrEP, then PrEP is not as expensive as having someone on HIV treatment for the rest of their life. And PrEP will cause drug-resistant strains is the other objection. The RPREX data didn't support that. There were no new drug-resistant strains in the RPREX study. I believe there were 2 cases of drug resistance, FTC resistance is one of the drugs, but those people on later analysis were found to have already contracted HIV before they went on PrEP, not while they were on PrEP. I just wanted to take a second to talk about PrEP stigma, and Edwina already touched on it. And the reason it's important, obviously in the United States, they've had PrEP for a while now, and ever since it was introduced, there's been a lot of let's say there's been some vilification of people who use PrEP. They're deemed to be irresponsible, or the term, and I don't like rude words, but the term Truvada whores was bandied around. And it seems that most of the stigma came from within the gay community, not from without the gay community. And that's why I think it's really important that we do talk about PrEP stigma at this stage, so that everyone who has feelings that lead to PrEP stigma, those people are able to voice those opinions and discuss them with other people, so that we can try and avoid PrEP stigma. Because in the end, any stigma has negative consequences for people, and PrEP stigma stops people accessing PrEP, and it stops people who need PrEP from accessing PrEP. I think in the end, PrEP stigma is sex stigma, just in a different jacket. And it's similar to the stigma that surrounded the introduction of the birth control pill in the mid-1900s. So maybe we haven't moved on as much as we thought we had. The rest of my talk is looking at PrEP in practice, so how the provision of PrEP may work in everyday sort of general practice, or maybe more specialised general practice. So these are the points I'll talk to you about. And first of all, preparing for PrEP. So who should consider PrEP? This is taken from a slide that was presented at the CROI conference in Boston earlier this year. But CROI is a really big HIV conference. And PrEP has the lowest number needed to treat, or NNT, in the following settings. It's not rocket science, but basically they said that the people who are most likely to benefit from PrEP are people who have multiple sexual partners, people who have a sexual partner who is known to be HIV positive, people who have STIs, people who reported the use of cocaine, and I think it's fair to extrapolate that people who report the use of methamphetamines in Melbourne would fall under that category as well. Obviously, methamphetamine use is much more common than cocaine use in Melbourne. And people who have receptive anal intercourse without a condom. Interestingly enough, in the same presentation, they also mentioned that studies have shown that doctors feel most comfortable discussing PrEP with 0 different couples. So these are couples where one partner is positive and one partner is HIV negative. But arguably, and we can talk about that in the discussion, but if you have a 0 different couple and the HIV positive partner is on treatment and undetectable, those people are they're less likely to benefit from PrEP than people in these situations. Now, this slide is just talking about who does consider PrEP. So the other slide was looking at the doctor's perspective, but this is looking at the patient's perspective. So this is from the Project Prepare 2 in Chicago, which is a PrEP demonstration project, not dissimilar to the VicPrEP study that's going to be run in Victoria. And these are the reasons that people gave for having joined the study. So they wanted backup protection in the event that condoms were not being used. Some people wanted PrEP because they were in serodiscordant, or as you prefer to call them now, serodifferent relationships, and they wanted more intimacy, and they felt that using condoms was impairing that intimacy. Other people feared their partner's infidelity. Some people said that they simply were not successful with using condoms. So whether it is because they had erectile dysfunction, and if they put on a condom, then they lose their erection, or there's lots of reasons we could talk about. Some people reported they were less likely to use condoms when intoxicated, either on alcohol or other drugs. And I guess that's one of the differences between PrEP and condoms. PrEP tablet you take in the morning when you wake up. Condoms you got to put on when you may be intoxicated and in a different state of mind. Some people reported that they were in relationships with a partner who is unwilling to use a condom. And the next point sort of ties in with that there may be power differential in a relationship, so people may not be in a position in a relationship to negotiate condom use. Some people reported multiple sexual partners. Some people were engaged in sex work, and in that situation weren't always able to insist on condom use. And this is probably more specific to the United States, but some people didn't have a healthcare provider and joined the trial so they could get healthcare. I'm hoping in Australia that's rarely the case. So, preparing for PrEP. So obviously the first thing that's important is gaining informed consent from potential participants. So someone's expressed the wish to join the PrEP trial or to take PrEP in a hypothetical future setting in Victoria when we can prescribe PrEP in general practice. These are the things that need to be discussed, obviously, and again, Edwina's already touched on some of these, but it's the effectiveness of PrEP, which we've already talked about, the importance of adherence, possible side effects. So like Edwina said, with tenofovir and Truvada, there's possible side effects on kidney function, there's possible side effects on bone density. Then there's the short-term side effects, nausea, headaches, tiredness. They tend to settle after some time. And people obviously need to understand the need for monitoring, and that means coming to see a GP every now and then. The other things that are important before someone started on PrEP is ensuring that they're HIV negative. I think Dean might talk about that a bit more later on. But basically, obviously, they need to have that HIV negative test, but then also we need to, the HIV test has a window period, so it may need to be repeated depending on whether they've had any risk of exposure in the window period prior to the test. We need to explore whether they have any other medical conditions such as kidney disease, and they need to be aware that other medications may interact with the PrEP drugs, and that includes herbal medications. So how do we monitor people on PrEP? We need to monitor their adherence, and obviously in the VicPrEP study that's done through surveys and blood tests. The other ways that people can be supported in their medication adherence is through pill reminder apps, for example, on iPhones. If you type pill reminder into iTunes, you'll find a couple of apps available. People can get dosette boxes, which is a little Monday, Tuesday, Wednesday, every day of the week box that you put a pill in. You can set your iPhone alarm, you make it part of your daily routine, you keep it, in the bathroom so that when you brush your teeth, you take your pill. There's all sorts of tricks. The other thing that needs to be monitored is obviously side effects of PrEP, again, kidney function, a few other things. And we need to test for STIs and HIV. And that's no different from normal STI testing. Now, stopping PrEP. How do you get off PrEP when your situation changes? I mean, obviously people go through phases in life. You may go through a phase where you have multiple sexual partners, and you might meet the love of your life, and you decide that it's just going to be you together, up in the mountains somewhere. So you don't need PrEP anymore. So what do you do? So if you're going to stop PrEP, you need to continue it for at least another 28 days after the last sexual intercourse without a condom, which is similar to the duration that people take PEP for, which is 28 days after an exposure. And obviously they need to continue using condoms after stopping PrEP, unless you're in the mountains together. Now, this last point is a little bit tricky, but what happens if you test positive to HIV whilst on PrEP? And I just put this slide in because it's the easy way out. But if someone tests positive while on PrEP, they need to seek urgent specialist review, because it is really, there's lots of different variables in that situation. I don't think this is the right place to talk about it, because it's really complicated and it really depends on that patient's particular situation. So I guess we could always, during the discussion, if people want to ask questions about it, we can have a bit of a talk about it. And this is my last slide. Don't forget about PrEP, because there's still a lot of people, this I find in sort of daily consultations, there's still a lot of people who don't know about PrEP. So you might already all know about it. I'm quickly going to touch on it. So PrEP is post-exposure prophylaxis. It's using the same drug, Truvada. If you've been exposed to HIV, or you think you've been exposed, you come and see one of us at any of the high caseload clinics, or if it's after hours, you go to the Alfred Hospital or one of the other big hospitals in Melbourne, and you say, I think I've been exposed, what do I do? And then we can give you, we'll talk to you about your risk, and we'll work out, is this a significant risk? Is it not a significant risk? And we'll work out whether you should be on PrEP. And PrEP is where you take Truvada for 28 days after an exposure. And it significantly reduces your risk. It's in the 90s, the risk reduction. But just thought, mention that. Does anyone have any questions?
Just in terms of what I'm going to talk about, and some of these things have been covered to a certain extent or to a great extent by the previous speaker, so I'll kind of skate over some things if I think that's the case, but talk about the potential role of PrEP, revisit the aims of the VicPrEP project, talk about the social and behavioural arm of the study that I'm involved in coordinating, look at some of the research that we've done at the centre I work at on PrEP use and attitudes among gay men specifically in Australia, talk about some of the adherence issues and the research on adherence, some of the elements that previous speakers have talked about in terms of concerns about changes in sexual behaviour among people on PrEP, and then also just close with just an overview of what participants will be expected to do in the social and behavioural arm of the VicPrEP study. So why PrEP? Probably this is already covered. Like, HIV risk is not evenly distributed across populations. Obviously people are at higher risk than others for a number of reasons, and these have mostly been covered, and that these obviously determine our eligibility criteria for projects such as VicPrEP. And also, as Vincent already mentioned, this is the same study he quoted from the CROI conference, that maximum effect of PrEP can be achieved if it's targeted to those most at risk, and also fewer people need to be treated to prevent infections that way. Also need to look beyond serodiscordant relationships. That point was made in the same project and the same study, and they call negative partners in serodiscordant relationships the low-hanging fruit. Of course they need to be considered, but we also need to look beyond that. And also HIV risk is not evenly distributed across time, so obviously people go in and out of periods of greater risk, and there's some quite well-known periods in which people are at high risk of HIV, might be entering new relationships and might be exiting a relationship. That's a really important one that's not probably considered a lot. Drug use and so on. In terms of the aims of VicPrEP, we're looking at, we're determining the uptake of PrEP among eligible participants. We're describing the duration and patterns of PrEP use, as already mentioned, determining the acceptability of PrEP, investigating the safety of PrEP, looking at changes in behaviour among people taking PrEP, also, as has been mentioned, looking at incidence of HIV and STIs, and also, ultimately, we are interested in determining the feasibility of providing PrEP in an ongoing way in Victoria. So this is actually the website of the study, and this is where most people, participants will enter the study, and as you can see at the bottom there, though, that's where they go to, yes, I have a cursor, to do their online study entry survey. There's also this website we hope will be a kind of a portal for information about PrEP. So it provides information about the study itself, the sites that are participating. There's a special area for participants which we have extra resources as well as links to the surveys. There's an area for clinicians and other healthcare providers with all the study documentation is there. A section of frequently asked questions, so that's people who might be considering going in the study, things that they might have, questions they might have about the study that they might want might want answers to before they go to a clinic and have a discussion with a healthcare provider about PrEP. And this has already been gone through. These are the participating sites. So why do we have a social behavioural arm? Well, there's an important number of research questions that we need to answer. Primarily, it's things like who's interested in PrEP and who actually takes it up when it's offered. So, as Edwina described, we've actually got these two arms to the study. So, we're actually looking at differences between people who accept PrEP, so our acceptors and decliners, as we call them. So, are there any things in terms of demographics, age, for example, relationship status, sexual practices, attitudes to things like PrEP, antiretrovirals in general, condoms, relationship with clinicians and kind of contact with clinical services, and perceived vulnerability to HIV. Also, we want to know what are people's experience of taking PrEP. So it's things like patterns of pill taking, product-related issues, like how do people feel about taking the pills themselves. This is something that's come up in a lot of the research on PrEP. People have very different reactions to the pills themselves. Things like colour, taste, size, they're all quite important things. Packaging even is important in whether people, how they relate to the actual the drug. Any difficulties or side effects as well they have, and disclosing to others and kind of the effects that might have and the considerations that people invest in making those decisions. We're also interested in how taking PrEP interacts with existing strategies to prevent HIV. They're already been described, condoms, insertive receptive roles, serosorting, HIV testing, and so on. Also, what are people's experiences of participating in the demonstration project specifically? So the clinical visits, the burden of, even though it's real world as we call it, it's every 3 months, which is what people would be recommended to be attending for anyway. How do people feel about that? The tests themselves, the experience with the pharmacy requirements, getting a script and then taking it to pharmacy. They have to pay the co-payment, so it's currently $36.10 or $5 something. Yeah. How they experience the data collection component. And what does PrEP mean to people who take it? So just turning to the research we've already done on PrEP use and attitudes, as Vincent already said, some people already do take PrEP. It's relatively small numbers in overall terms. We find less than 2% of men in gay surveys in Australia report using antiretrovirals for prevention, for pre-exposure prophylaxis. But in Australia actually has, we have a high proportion of people who use post-exposure prophylaxis. Around 3% report having had PEP in the last 6 months, and approximately 15% of gay men in our studies report that they've ever used PEP. There is some confusion and overlapping we find in the research around PrEP and PEP. Some people using PEP as PrEP, some people, when they're asked about PrEP, they say they're taking PrEP, but when they're asked more questions about it, they say they're only taking it after exposure. So some of these things are a little bit loose. We also did some research on, starting in 2011, which was just the first few months after the first PrEP study among men who have sex with men was released in late 2010. And we wanted to investigate whether men in Australia, HIV-negative men, were willing and motivated to use PrEP. And what we found was around 28% were willing and highly motivated, which is quite low compared to international comparisons, but I'll explain that in a moment. But what we also found is when we repeated the same survey last year, that in fact interest in PrEP or willingness to take it had actually dropped significantly. Although it looks quite small, 28 to 23%, that was actually a significant drop. And we have different ideas about why that might be the case. But those who were most interested in PrEP were actually, they were more likely to have an untested or HIV positive regular partner as opposed to a negative partner, or to have only casual sexual partners as opposed to having a regular partner. They were more likely to perceive themselves as more vulnerable to HIV. They had fewer concerns about PrEP. We asked a whole lot of issues, so they had fewer concerns about side effects, other effects of PrEP. And they were more likely to have previously had post-exposure prophylaxis as well. Just quickly, this is one of the reasons why we have a low measure compared to international comparisons on interest in PrEP. When you ask people these really general, these were the actual 7 items that make our kind of willingness kind of measure. If you ask people really general questions about, would you be willing to take PrEP to prevent HIV? Yeah, around 80% say, yeah, sure. And similar questions like that, very general questions, you get a high agreement. But when you look at things like, would they be take it even if it wasn't 100% effective, you get much lower, you get around 50%. You know, whether people would be willing to pay for it, much lower, and really low is things like, I'm going to take PrEP as soon as it becomes available, is the rest of that statement. So that really drags down. So obviously people have a general positive attitude towards PrEP, but actually very few, only around a quarter, see themselves as being in a position where they would likely take it up in the very near future. And who actually takes up PrEP? We actually have some findings from some studies in other settings. There's a new study in the UK that's just finished enrolment, and this is it's among gay men, and it's so the mean age was around 35 years. The people who enrolled in that study had 10 sex partners in the last 3 months, and around 50% of those were unprotected sex. A range of status of their partners, a third were known to be positive, and 81% of those on treatment. 40%, so that's a really high proportion, had some previous experience of post-exposure prophylaxis. And that's within the last 12 months, so that's very high. In the demo project in San Francisco, they had an overall uptake of 49% of eligible participants, and the reasons people gave for declining PrEP, and this was gay men, things like not enough time for study participation, side effect concerns, or they didn't perceive themselves at being at sufficient risk of HIV. PrEP uptake was also higher among those with prior knowledge of PrEP and reporting high risk. And that study also had a very high retention rate, and we don't have much data on retention, for example, especially in these open label studies where these are people who know they're getting PrEP, so it's different from randomised studies where they don't know whether they're getting the placebo or the real thing. And they actually managed to retain 92% of their participants. In terms of adherence, which has already been talked about as being an important and difficult area, we know that it can be difficult. In randomised studies, it varied extremely widely across the studies, and drug level testing indicated that adherence was much lower than reported in every case. In fact, some of this has already been described in terms of the PrEP study, but there actually are some early studies looking at what's called intermittent dosing, which is not taking PrEP, so not taking Truvada every day, but taking it one day, for example, Monday and Friday, and then maybe a dose around sexual exposure as well. But in fact, adherence to intermittent dosing was in fact poorer than daily dosing. So whether that's intuitive or not, that's what these studies are showing. And in a study that just reported, which is the same one on the previous slide, the demo project in the United States, there was a really strong variation between different cities that were involved in this study. So in San Francisco, where they had more than half the participants who had drug levels consistent with daily dosing. In Washington DC, it was only a third, and in Miami it was much lower, only 1 in 7. And if we're using that threshold that we talked about before, at least 4 doses per week, which confers equivalent of a 96% reduction in HIV risk, you get 92% of participants in San Francisco met that, 80% in Washington DC, and only just 58%, so just over half in Miami. And there are a range of factors that come from all the studies that are related to increased and decreased adherence, and so experience of side effects, perceiving themselves to be at higher risk, motivation, trust and support, age, gender in the Bangkok and Ophivir study of injecting drug users. Decreased adherence is related to intermittent versus daily dosing, as I just mentioned, post-coital dosing, younger age, having less sex, alcohol use, and also PrEP use longer than 6 months. So that's a really interesting one for us to think about. In terms of concerns about changes in sexual behaviour and practice, as already described, none of the studies showed an increase in sexual behaviour among the participants in the study. So in the randomised controlled trial, the PrEP study among men who have sex with men and transgender women, there was a decrease in receptive anal sex and an increase in condom use. And also however, when they looked at when people who believed they were receiving Truvada, so people obviously in this study, in this phase of the study, didn't know which arm they were on, but those who believed they were receiving Truvada, they didn't either have an increase in receptive anal sex without condoms, but neither did they decrease their risk after stopping Truvada. In another study in the United States among gay men, there was a decrease in number of sexual partners and proportion reporting unprotected sex during follow-up. And the number of anal sex without condoms remained stable. In the partners PrEP, which is of serodiscordant couples, the frequency of sex without condoms between the partners didn't change following the unblinding. However, interestingly, and I think this is something we also need to think about, is that there was in fact an increase in the frequency of sex without condoms with partners outside the relationship. So that's a really interesting thing. So obviously people in serodiscordant relationships are not only at risk from their HIV positive regular partner. There might be other factors which put them at risk of HIV. So in terms of the requirements of the VicPrEP participants in terms of the social behavioural arm, There is a study entry survey which takes approximately 20 minutes, and it goes, we ask people to provide demographic details, information about the HIV and STI testing, any previous experience they have of PrEP and PEP, their relationship status, sexual practices with regular and casual partners, condom use and other risk reduction strategies. We ask sections on their views on antiretrovirals as treatment and as prevention. We ask about attitudes to condoms and a block of questions about their experience of this study entry visit. And then those who are the PrEP acceptors, they are asked to complete quarterly surveys, and they're much shorter, about 10 minutes. They're completed online as well. And their experiences of taking the pills, any problems they have, missing doses, disclosure about being on PrEP, to who did they disclose, partners, friends, family, whatever, and the experiences and any negative reactions they had to that, or indeed positive reactions, relationship status, sexual practices, and so on, and ongoing feedback about the VicPrEP project. And this is important and something quite different around a demonstration project. It's a way of actually providing real-time feedback about how participants think the project is going, and that information can be used to make changes to the study or to provide feedback in general terms to the participating sites and to the investigators of the study. This is just what that section of the website looks like. There's a range of additional information people are given about PrEP there, some fact sheets, links to some sites in the United States as well. And also there's an optional face-to-face interview for the PrEP acceptors. So we're looking at getting a small proportion, around 20 at least, of participants to agree to take part in an interview, which is face-to-face. It takes just under an hour approximately. And we ask them to do that at 2 time points. So the first time point is so in the first month after they start taking PrEP, and then a follow-up 12 months later, around the time their period on PrEP will be coming to a close. And in that interview, we'll be looking at things like experiences of taking PrEP, again, disclosure and reactions, social concerns, sex and relationships, and their incorporation of taking PrEP into their everyday lives, changes over time, and also their reasons for taking part in the project and why they continue to be part of the project and how they see their future as well. So we think this is an important part of the study, and not many studies have actually had this component, so we're quite pleased to be able to provide this as well. And that's the summary. Thank you very much.